Hi there, my name's Kathleen. I'm an FY2 working in palliative care at Mercury Hospice in Glasgow. I started my foundation training in Monklands Hospital in Lanarkshire, where I did general medicine posts based mostly in endocrine and care of the elderly, and then a job in general surgery. I then started my FY2 in obs and gynae at the Royal before moving on to palliative care. Due to COVID-19, our rotations got cancelled, so I've actually been in the hospice for the past 8 months. Working in palliative care has a lot of similarities to other FY1 and 2 posts. Your role is mostly ward-based. You go on the consultant ward round, and it's your responsibility to carry out a lot of the jobs generated from this. So your day-to-day jobs can include doing bloods, organising discharges, arranging scans. You're also the first port of call if any patients need reviewed or become more unwell. But there are also quite a lot of differences to working in hospital-based jobs. I think one of them is you get to know your patients very well, both in a medical sense, in that you understand their diagnosis and their clinical management plans, but also on an emotional level. You get to know a lot about their lives, what's important to them, things like that. And you work really closely alongside the MDT, so physios, occupational therapists, social work, but bereavement support, counselling, things like that as well. I think one of the biggest parts of our job is communication, and that's both with patients themselves, trying to explore what's important to them, what their thoughts, what they're worried about, but also communication with families. It's our responsibility to keep them updated, relay information, and often have discussions about anticipatory care planning, so ceilings of care, things like that. And I think that's probably one of the biggest challenges of working in the hospice during the coronavirus outbreak. We're used to relatives being around a lot of the time and being able to keep them updated as you're reviewing patients, but for a period of time we weren't allowing any visitors into the hospice, which has been a huge shift in our job. We've been having to give a lot of updates over the phone, and I think initially that was really difficult, not having all these non-verbal communication cues that we're used to, being able to see how comfortable people are with the discussion you're having, picking up whether they're getting upset, are they understanding you, things like that. I think doing a lot of these discussions over the phone has been a challenge, and understandably you deal with the frustration of these relatives. They've been there with their loved one through a long period of time, for some of them with their diagnosis, and then not being able to see them is a challenge for them too. So I think that's probably been the hardest part. There are some visitors allowed in just now, so we are getting some of that face-to-face communication back, but it's definitely been a challenge. I think a lot of people perceive the hospice as being full of patients at the end of their life, but this isn't always the case. People come in for a period of assessment or symptom control, and your job is to explore what's been happening, establish the problems, and try and get things a bit better for them. So sometimes people are in for spells of assessment or symptom control, and they get back home again. I think as a foundation doctor, the experience of working in palliative care has been invaluable. I think you learn so much about being able to have these difficult discussions, and you just get opportunities that you wouldn't get in a hospital-based setting. I think it's enabled me to feel more confident having discussions about do not resuscitate, ceilings of care, things like that. And at times you do break bad news as well about scan results, things like that. I think it really has been invaluable, and a lot of these skills, mostly communication, but in medicine as well, are exposed to so many different pathologies. You get more comfortable prescribing the drugs used at end of life. I think they're all important skills, and I think a lot of these skills are transferable to other jobs. And for me, I hope that I'm able to use them in wherever I work next. But I think it's a great job to have as an FY1 and 2, because you are so well supported. There are loads of opportunities to learn from your seniors, having discussions with families, with your registrar, your consultant there. I think you learn good phrases to say, things like that. It's been really helpful. So I hope this was helpful, and good luck to you all. Thank you.